training at
Recording. Thank you.
I went through my medical training at Columbia University and realized there were some gaps, as a lot of people do, in regards to HRT. It's sort of this whole area of medicine that we don't get very much training in. So when I started doing training in anti-aging and functional medicine, hormone therapy really took center stage, and there was all these studies being referenced that were not part of the popular narrative. So I dove into a lot of the studies. There was a lot of European studies. There was a lot of European doctors that lectured at conferences I went to, people like Terry Hertog, who's a fourth generation endocrinologist. And, I realized there was this whole other world of HRT and compounded hormones that were being utilized in other countries that nobody here seemed to know anything about. Um, but this topic was brewing here, and there was some renewed enthusiasm, but we were coming off the Women's Health Initiative study fallout from the year 2000. People are heavily indoctrinated in a particular sort of dogmatic discourse around HRT. And so, I knew there was controversy, and I think I'm sort of attracted to controversy, and there certainly was in this area of medicine. So I sought to kind of unpack that, and in doing so, I learned a lot, and I started advocating for patients and educating patients about 15 or 16 years ago. And at the peak of my very busy practice 10 years ago or so, we had, four or 500 women on HRT. So over the last 15 years, we've treated thousands of women on HRT. I have women as old as 90 on HRT, women as young as in their, late teens or 20s on various forms of HRT. We haven't shied away from certain forms of hormones like testosterone that are not commonly prescribed to women. Again, most of what we do, if not all in regards to hormones, seeks to be very evidence-based. We just look at a very large evidence pool and sort of look beyond our borders to see what's happening in other countries with other guidelines and try to get out of this sort of dogmatic stance and kind of brainwashing that happened here in the United States, which, my posture sort of on this topic writ large for postmenopausal women is that we've done much more harm than good in 25 years of denying women HRT and making it controversial in the United States. So we've sort of expanded the where we've gone with this a little bit. We're now treating some breast cancer survivors with certain forms of HRT, continually looking at studies and trying to stay up to date in this area and educate women as best we can. Fortunately, the last few years, we've had kind of social media come to our aid, and now we have a lot of influential podcasters and gynecologists sort of echoing the things that we've been saying for a long time, which I think is really helping move the collective consciousness forward. And now a lot of women are kind of waking up, realizing there is a newer, evolving story. They're reading books like Estrogen Matters. They're watching podcasts. So I think that's a good setup for this conversation today. Is this kind of changing landscape of HRT, how people are waking up, how popular narratives are changing, and what does all this stuff tell us now, and how can we think about hormones now in a 2025 context, and what really is the promise of HRT and the opportunities of HRT in women and men too. We can talk about men as well today. We can throw all genders into this topic. Men, it's the controversy wasn't quite as extreme, but certainly there's a lot of dogma, misinformation also that prevents men from easily accessing, say, testosterone therapies, for example.
Love it. Okay, no questions yet. So let's get some brave souls to ask questions, but I have some questions I can kick us off with. So my sense is the education gap and the myths around hormones have really shifted in the last couple of years. Like the public is a lot more educated, but I'm curious if there are still like one or two kind of remaining myths that you're still hearing or people are still asking about.
The thing I probably hear the most is, "Hey, I'm 65 or 70, hormones are off the table," right? Well, if you look at the 2022 North American Menopause Society guidelines, things have certainly evolved, but it seems like 95% of doctors aren't aware of the evolution here. What seems to be the case, and we have a study with 10 million women, Medicare recipients, 1.5 million of which are on hormones, show us clearly that if you're on certain types of hormones, there really is no, stroke, heart disease, or increased breast cancer risk. Instead, you get 20 positive benefits. So a lot of this historic noise about cutting women off at a certain age, of course, is based on the Women's Health Initiative study, where older women on synthetic hormones were found to be at slight increased risk of things like stroke and heart disease and breast cancer. Therefore, we had guidelines around 2001 that said, hey, don't give women over a certain age hormones. And it was all based on WHI. And like a lot of things in medicine, people just kept regurgitating this ad nauseum without thinking that it came from a single flawed study, which we now know in hindsight There was a lot of problems with the study. The hormones we use are not the hormones they used in the study. The women had some health challenges at baseline, which predisposed them to certain things. And the risks even of the synthetic hormones in those older women in the Women's Health Initiative study were pretty overstated by many accounts. So the age thing comes up a lot. Women can still benefit from hormones after a certain age, and in the right context, these are deemed to be safe by the latest slew of studies. So, what's a good example of a risk benefit for a woman over 65 potentially starting HRT would be bone loss or osteoporosis. Hormones used to be a gold standard way of improving bone density. And then around the time the WHI study came out, we had drugs like Fosamax come out. So those kind of took over center stage for helping osteopenia and osteoporosis. And we started to demonize and deny women HRT, which had historically been a gold standard treatment. So over 65, if you have bone loss, I would make the argument that estrogen is probably safer than bisphosphonate drugs and more effective, certainly. So a lot of women could be candidates based on that. There could be sexual dysfunction that uh, creates a risk benefit for a female patient. Estrogen, of course, helps incontinence, the pelvic floor, vaginal dryness, sexual health, well-being, and many other aspects. Uh, Dementia risk is increased in younger women who go through menopause early. So if a woman hits menopause at 40 or has surgical menopause, they're going to be at higher risk of Alzheimer's disease. So, we've wondered for a long time, is there a window of opportunity to give estrogen to potentially offset those risks in the female brain? And it does seem like that's true. So some of those older conclusions seem to hold true here. If you start a 70-year-old on hormones who has not been on hormones from age 50 to 70, you're probably not going to get a big brain benefit. So there is some tissue specific benefits in starting HRT after a certain age, but we should no longer, and again, the NAMS guidelines back this up, categorically deny women hormones at certain ages or apply arbitrary age brackets to HRT conversations, which unfortunately, again, in 95% of clinical settings, that's still happening.
Yeah. I have a question that I get asked about a lot. So a lot of younger men are having issues with testosterone. I feel like that's becoming more and more common. And I know there's some contraindication with like reproductive age men and testosterone. So what tools do we have? Am I even right about that? How would you address that?
Yeah, I think this is actually a really interesting topic, and it speaks to, how life on Earth is changing in not a great way for human physiology. We have very accurate sperm records, for example, going back to the 70s. And sperm banks have to count your sperm. So it turns out their records of what a sperm count looks like are very, very accurate. So as early as the early 2000s, we noticed that sperm counts in men had gone down 50% since the 70s. So, guys who donate sperm tend to be in their, 20s, 30s, 40s, et cetera. So something had shifted in male fertility in a major way. I mean, our procreative ability had plummeted. And beyond that, we also know that there's more of a testosterone decline than we've seen historically. So men in their 20s, 30s, 40s are walking around with lower levels of testosterone. Now, part of that can be explained by the growing epidemic of metabolic disease, which could be defined as, you know, all sorts of things: dyslipidemia, high waist circumference, obesity, fatty liver disease, diabetes, prediabetes, insulin resistance, etc. This sort of toxic metabolic glucose dysregulation brew certainly doesn't help your endocrine function. Add to that things like sleep apnea, which are worse with obesity, which also affects testosterone in men. Add to that environmental toxins and chemicals, which we know are known endocrine disruptors. So you have all these things and stress writ large. So if you're stressed, your body is going to be making catabolic hormones, not anabolic hormones like testosterone, growth hormone, and DHEA. So I think we are, seeing that in clinical studies that men are showing up to clinic with lower levels of testosterone. So how can we address this in younger men? So I think it's our responsibility if a 25-year-old comes in with low testosterone to try to identify causative factors. And if we can, and they can correct their lifestyle and make improvements, great. If not, then we're also not going to deny them HRT just because they're young, right? So we're going to try to identify the problem and fix it. If we can't, there's various ways of delivering testosterone to younger men who need it. In a younger guy, we're often trying to stimulate their own production with drugs like Clomid and clomiphene. In middle age or older men, we're often just giving them injectable testosterone because that's a very predictable and established way to increase it. There's some newer treatment. There's an oral drug now called Cazastrix, which doesn't seem to affect fertility in men. That may be a good option for younger men. So there's some newer things in that space, but to make it simple, younger men, we sometimes bat around two or three different options. Older men, typically we use standard treatment, which is 100 milligrams or so a week of testosterone cypionate.
Love it. Perfect. Okay, we got one question from Jennifer. So she says, it seems like estrogen isn't typically prescribed until a woman has gone through menopause. At least this is her experience. Under what circumstances and when would you consider starting before a woman has fully gone through menopause? And in what situations do you consider adding testosterone? Curious what the research is supporting.
Yeah, that's a great question. Thank you for asking that. This is coming up more. So I think for us, again, there's no age where we're going to say we're not going to give you estrogen. We're going to look for symptoms of deficiency as well as blood levels. And we know that estrogen levels can decline before they go to zero. So if you're expressing symptoms and you're especially late perimenopausal but haven't hit menopause yet, we often are happy to trial women on estrogen. In regards to studies on that, you know, I, I'm not aware of a ton of studies on, late perimenopause, estrogen patches, but it's this is more in kind of the common sense realm. Estrogen deficiency symptoms are not particularly ambiguous, and you can have low estrogen before you stop menstruating. So I think that's the key point to know. So what are those things? I mean, if you're, 45 to 50, menstruating, regularly, but having some night sweats and hot flashes, vaginal dryness, brain fog, dry joints, arthritis, worsening osteoarthritis, uh, tendonitis, frozen shoulder, a lot of that stuff can relate to changes in estrogen levels in the female body, dry eyes. So, we might look at your estrogen levels or trial you, on a low dose patch. The patch comes in 5 doses. It's bioidentical estradiol. So it might give you a 0.025 milligram patch and say, are those symptoms better? And a lot of women say, yeah, I do feel a little better because you're supporting that sort of declining estrogen pathway. And if they really are not ready for estrogen yet, you're using such a low dose that you're not likely to cause any harm either. And in maybe a worst case scenario, a female who's given estrogen when she doesn't need it may have a little more PMS or estrogen dominant symptoms, could have a little bit of spotting, could have some breast tenderness. And again, those would be easily resolved with withdrawing the estrogen. And again, you have a lot of doses to choose from, even among commercial estrogen products. So if the shoe fits, a woman is of a certain age, they're starting to express those symptoms, we're not really hesitant. Most doctors are, though. They're really looking for slam dunk menopause. And I think it's because they're scared to give cycling women estrogen. Really, that's kind of what it boils down to. But when you step away from that fear and you look at hormone changes that occur in women in their late 40s, you realize that you're sort of supplementing something that's becoming more deficient in the same way that we do it a little earlier, often with progesterone, for example, or sometimes even testosterone. So, yeah, you don't have to wait till you haven't had a period in a year, though you will hear that from some other clinicians. So, again, why make women suffer when it seems more likely than not they're at menopause's doorstep? If you're 20 and you're having low estrogen symptoms, we're going to seek to understand that really fully, before we give you estrogen.
Totally. I think we touched on this in our last hormone talk, but I'm also curious, is there like a critical window when maybe a woman isn't having symptoms, but if she's going to reap the most benefits from hormones, should think about kind of having that conversation with the provider? And then with men too, is there kind of a critical window?
Yeah, good question. So in regards to women, the first 5 years of menopause is pretty critical for the brain, cardiovascular system, and bone density. So even if a woman is mildly symptomatic, we want to make sure the tissues that benefit the most from estrogen are not suffering. So in regards to the brain, that's a little harder to deduce, but if there's any cognitive issues, we want to be attentive to that. In regards to bones, my belief is every woman should have a baseline bone density scan in their 40s and the second one at menopause, so we have clear baselines on what their bone mineral density is. And if there's any change in bone density in 2 year intervals from menopause forward, uh, they've just elevated their candidacy for hormones quite a bit in my mind, because if you save somebody from osteoporosis and fractures, you've done a lot more than most doctors are doing in most contexts. Frailty is not great, and it can be totally avoided if the hormone shoe fits, so to speak. So, mortality statistics among women who have hip fractures in their 70s, 80s, and 90s are very scary things to look at. Most of those people are dead within 6 months of their first fracture, and they can't walk across a room unassisted 6 months after those fractures. So, fractures at those ages are absolutely debilitating to health, and they can be totally avoided mostly if we're really attentive to the changes that occur in female bones and we're not scared to give women hormones. So that's an easy thing to assess. Cardiovascular health, I would say as well. You could do things like carotid ultrasounds, coronary calcium scores, more fully explore family history and risk factors. And there's more evidence than not that the right form of hormone therapy has a protective effect on the vasculature. It lowers sinister atherogenic particles like lipoprotein little a. It has a positive effect on HDL. It has a positive effect on the endothelial lining. It has a positive effect on nitric oxide. Uh, Hormones do a lot of positive things directly to the cardiovascular system in men and women. So, being attentive to these tissues that are affected by hormones and seeing if there's clinical evidence of something or a disease process starting that could be benefited from HRT. But yeah, that critical window for women to start paying attention to this stuff, certainly 50 to 55. For men, andropause is a slow progressive process. So the window of opportunity is a little harder to answer, but I think men should also have a baseline level of testosterone as young as possible, should be checking their testosterone levels, once a year, once every few years. If there is a more than expected decline, and they're starting to express some symptoms, at that time they can approach treatment and they will be on a little bit of a course correction. Men also need testosterone for bone density because men only make estrogen through conversion of testosterone. So if a man has low testosterone, he has low estrogen. If he has low estrogen, he's going to be at higher risk for osteoporosis, maybe cognitive decline, also osteoarthritis, probably, and other things that estrogen protects men from. So in men, I often get these guys that are older, and I'm left wondering what their testosterone level was when they were 20 or 30. And infrequently do we have that kind of data. So I think, it would behoove, primary care doctors to be checking people's hormones over time, but they don't because they don't know what to do with it. They don't know how to treat it, and they don't really understand the rationale. They're happy to check your blood pressure every time you're in there and put 80% of their focus on your blood pressure management, but there's all these other things that could be attended to.
Yep. All right, we're getting a couple of testosterone questions. So the first one is, can you speak to the pros and cons of testosterone versus Clomid for treating low T?
Yeah, so that's a good question. I think there's no generalized answer to this question. It's sort of whatever works, but Clomid tends to work better in younger men. I have seen it work in men in their 50s, but more typically we're giving it to guys, I don't know, age 20 to 45. Clomid is a drug that stimulates the pituitary gland to make a little more gonadotrope hormones, which are a luteinizing hormone and follicle stimulating hormone. So when the brain makes stronger signals, those signals activate receptors in the testes and create more endogenous production of testosterone. So it is a clever way to get a man's testes to produce more testosterone. So not supplementing testosterone, but actually enhancing your own production. So that can work pretty well. Clomid can have some side effects. Sometimes it can raise estrogen too much. Sometimes its effect in raising testosterone is less predictable than real testosterone. And Clomid is a dual isomer drug, so sometimes the non-active isomer can have some side effects in some men. Whereas testosterone therapy is, it's if you're looking for predictability, injecting testosterone is very predictable. When you inject it, we know the blood level is going to go to a certain range. So sometimes there's something to be said for predictability. But if a young man or younger man is trying to kickstart his own production, preserve his own ability to produce, or simply likes the idea of being able to produce more himself, drugs like Clomid are maybe a good option. And clomiphene is a better option than Clomid. It's a compounded version of Clomid that I'm now more in favor of than Clomid. And that's a single isomer of the drug Clomid, so it seems to have less side effects. And in my anecdotal experience here, it seems to raise testosterone levels to similar ranges as injectable testosterone. So the only downside is we don't have a ton of studies on enclomiphene. We don't have studies on men using Clomid for 20 years, so hard to say exactly. But the available data on Clomid-like drugs is pretty good, and we have an aggregate of data for several decades now. So, and clomiphene is great, 25 milligrams every other day is kind of where we start with that. And I've seen patients get up to, eight, 900 in their blood level of testosterone. And then there's this new treatment, which is testosterone, but in an oral delivery form that bypasses liver metabolism. It's called Cazastrix. That releases the testosterone more in kind of a pulse wave, kind of similar to how the testes do. And it seems like that drug has less effect on changes in testicular volume or fertility. So that's newly FDA approved, I think, a couple of years ago. So we're exploring the use of that. It's also oral, which some men don't want to inject testosterone. Um, so we'll see how guys do on that. It's a little more expensive than some of the other forms. But I think all these things, men should be aware of all these treatments. There's sort of pros and cons to all of them. Um, but yeah, Clomid and clomiphene can work well.
Cool. All right, so question from a middle-aged man. Free testosterone is in the middle normal range, but total testosterone is in the low 400s. What does that necessarily mean and how to increase total amount? I think just adding on, Jeff, I'd be curious, what are you checking beyond total testosterone and kind of why do you care too?
Yeah, there was a follow-up question I saw on the screen to the last question, which is how do you spell clomidin and clomiphene? Clomid is Clomid, and clomiphene is Enclomiphene. And yeah, if you throw that into ChatGPT, you can read some stuff on it. So this question, and maybe Tara, correct me because I was distracted for a second, is in regards to, cutoffs or thinking about blood levels of total and free testosterone.
Yep. So, yeah, free is in the middle normal range, but total testosterone is low at in the 400s. What does this necessarily mean and how to increase the total?
Yeah, so that's not something we see a whole lot where the free is normal and the total is low. What that means technically is that uh, the body is doing a good job freeing up what is being produced. And your body has a kind of a mechanism for releasing testosterone. If you made testosterone and it all went into your bloodstream as free, it would be too much of a good thing, right? So 95% of testosterone on average is kind of bound up because you don't want it all going into the cells and hitting nuclear receptors at once. So the body sort of has a process for kind of gatekeeping testosterone, and it uses sex hormone binding globulin and albumin as protein binders in the blood. So if the free level is normal, it just means that either the body or naturally, based on how this produced person makes SHBG, which is sex hormone binding globulin and albumin, the levels are not high enough to bind it all up. Or it could be that in the body's own intelligence, it realizes there's not maybe enough total, and so it's freeing up more. We don't see that more commonly. We see normal levels of total testosterone and low free testosterone. So how could you create a higher total in this context? I don't have a great answer for that, but the general things that might improve testosterone, I think would hold true here, which is, basically adequate sleep, stress management, eliminating or reversing any risk factors for low testosterone like sleep apnea, metabolic disease, obesity, inflammation, overstress, lack of sleep, exposure to environmental toxins or chemicals, and exercising, particularly weight training. So if all those things are going on and the total output is still not what it should be, you may not be expressing a lot of symptoms if the free testosterone is consistently normal. But let's talk about what's normal. So, the testosterone ranges are all over the place depending on the lab that you look at, anywhere from 200 to 1,000. Optimal range is probably more like, 700 to 1,000 or 700 to 1,200. If a man comes in with a testosterone of, 400, everybody will tell them it's normal. But if their baseline is 1,000, are we led to believe that a 60% decline in your baseline is normal? I don't think so. So if men are clearly lower than their baseline, or they're in these kind of intermediate ranges but are expressing symptoms, we have some studies showing symptoms can manifest when testosterone levels drop below 500. So, I think it's reasonable to treat men in those ranges if they express symptoms and if a trial of testosterone alleviates those symptoms. There's a lot of things that can cause fatigue, so we're not always thinking you're low in testosterone if you're just fatigued, unlike the advertisements on the radio. But we're looking for a constellation of symptoms. You have all the testosterone-related symptoms, levels are, normal or low normal or clearly low. Patients interested in a trial of treatment, we can explore that. In regards to free testosterone, it also depends on the lab. I've seen a pretty wide range here as well, anywhere from 50 to 150 or 50 to 300, or if it's expressed differently, like with LabCorp, it might be 5 to 15, that kind of range, 5 to 17, because it's using a different unit of measure. Um, but if we're using the 50 to 250 range, like Quest has, for example, we know that men can become symptomatic under 100. So I think, under 100, I'm starting to wonder if there's symptomology, free level, or sorry, total level as well. If it's less than 500, certainly less than 400, I'm asking patients questions about any testosterone-related symptoms. And some of these are gradual and progressive over many years, so they don't hit you in the face like menopause. So that's the real difference between andropause and menopause is, the time horizons here are very different. In men, it's a slow and steady decline over 60 years. In women, it's an abrupt change in some period of months.
Totally. Okay, so one question, the oral testosterone, the new one, that was wondering how to spell that.
KYAZTREX, I think.
I
Or
can look it up
KY,
too.
KYAZTREX,
Okay.
something like that.
Yeah, we'll find it. Okay, so if a young adult woman is at a healthy weight from muscle and has a very low body fat percentage, around 12%, long unpredictable cycles, and heavy periods with symptoms of PCOS, what are we thinking would be important to focus on? Is this a result of low body fat associated with altered hormone production in women?
Yeah, it could be. I mean, that doesn't fit all the sort of classics of low body fat induced like amenorrhea, but more classically, if a woman has low body fat and is overtraining or exercising, let's say too much, we see this a lot in, high school athletes. They may not have a period for 5 years if they're Division I athletes or something. And unfortunately for those women, they lose bone mass. So there's been a lot of studies in this group of women where they give them hormones. So here's a case where you can give, and I'd be happy to do this too. If I have an 18-year-old who wasn't having a period and their percent body fat was 12%, I would be giving them estrogen or birth control pills so that they have a little bit of protection against bone loss. So I think when your body fat is very, very low, or certainly well outside of a normal expected range for a woman, you're going to have you may have endocrine changes associated with that. Um, you know, very lean sort of state. And though it may not typically cause more PMS or prolonged days of menstruation, more classically, you're going to get absence of periods or you're going to miss a period for several months. But sort of in general, that's that's a profile where you might expect some endocrine shifts. Now, the PCOS that you're describing could be distinct. There could be a compounded issue. There could be something else driving PCOS. Generally, that's driven by metabolic disease, insulin resistance, circadian rhythm imbalances, and other things. So there may be two distinct things going on here. I'm not sure. And that's where you can get irregular menses. You can get, acne or facial hair growth. You can get cystic ovaries, which can increase the production of androgenic hormones like DHEA and testosterone. So I'd be trying to kind of parse out, what is body compositional induced endocrine dysfunction versus is there some, distinct just PCOS that's not related to that or overlaps. But that particular case could be a little more complex.
Cool. Okay, we have one more. Do you use HCG with TRT for your patients who don't want testicular shrinkage?
Yeah, we do. And we used to do a lot more of this. It was very easy to get HCG 15 years ago. Anybody would compound it for you. It was like, $50 a bottle. And we had a lot of guys who were interested in using it. And there was some doctors at the time, like Chris Crest, what was his name? There's a guy in Colorado who was becoming popular that people were seeing who was big into this idea. So at the start of my practice, we had a number of guys on HCG. Typically, we'd use 250 or 300 units twice a week, subcutaneous, along with their testosterone. And, in most guys, that prevented testosterone solo treatment, testicular atrophy. Then, the FDA sort of put the kibosh on compounded HCG and other drugs of biological origin. I think HCG was obtained from pregnant animals, or I'm not sure how they got it, but it was a biological drug. So anyway, it got a little more expensive, and a lot of guys didn't want to pay the extra cost. So slowly but surely, over 5 or 6 years, I got down to just a smaller handful of guys using HCG. But yeah, if a man wants to use HCG in tandem with testosterone, relatively low dosing can help preserve testicular volume, but it's not without needing to do more injections and potentially paying an extra. It's not exorbitantly expensive, but it might be around 100 to 150 bucks a month to do that.
Okay, we don't have any more questions, so keep them coming, but I'll ask a question. Um, I'm curious, I feel like in a lot of the voices that are emerging, there's still a debate of compounding versus not and pellets versus not. So I'm curious about your take on that and how you would kind of walk someone through that.
Let's talk about pellets for a second. I think a lot of women are and men too are becoming aware of this implantable, bioidentical pellet option. Pellets last, they're so hard, they're like rocks basically, that they dissolve very slowly. And so they dissolve over 3 to 5 months typically, and they can give very good stable relief of certain hormone-related symptoms. Uh, if you talk to people who are adept in prescribing hormones every way that's available, I think you can get a good lay of the land. Some doctors who, say this is the best thing or the worst thing may be more limited in the types of things they offer. Uh, we've always given like all the different hormones, so I think I've developed a pretty good sense of, when the shoe fits, use this or that. So I try to get to know my patient, and then I can advocate for a particular type of HRT. But in general, where testosterone pellets, which are all compounded, by the way, there is a FDA-approved pellet product for men called Testopel, but the compounders do a great job making pellets, and we have a wider variety of doses and options through our compounding partners. But where it really seems to fit for women is when women are really having symptoms of low testosterone and they want quick resolution of those symptoms. Um, I think a hormone pellet is a good option. Testosterone creams and gels can work great, uh, but pellet delivery leads to the best improvement in testosterone-related symptoms from anything that I've worked with personally. So, sometimes I have female patients who are very testosteronogenic by nature. They're very driven. They're very athletic. They're used to running 3 or 4 companies, and all of a sudden they hit menopause and they feel like crap. And for them, a lot of that could be related to a big change in testosterone. So I want to make sure those women are supported, and pellets are a good way to do that. For other women, that may not be the hormone that's taking center stage. So we may not need something as aggressive as a pellet. We can use a cream or gel, or a lot of women we may trial on a cream or gel too. And if they're not getting the relief of symptoms they want, we might move to a pellet. Uh, Compounded hormones, unfortunately, a lot of the stuff that we use is not available in commercial forms, or compounding allows us the flexibility of combining 2 or 3 hormones together, or customizing a base or a dose to an individual patient. So people may wonder, why are a lot of my prescriptions for hormones being compounded? And for things that are not readily available commercially, or in the dose or delivery that we want, we turn to our compounding vendors. For example, there's no FDA-approved testosterone product for women, so we have to compound it unless you use a male androgel product, which would be way too much of a dose for a woman. So, and I have seen some gynecologists tell female patients, go ahead and get the Testim packets, but then their insurance is not going to pay for it, and they have to approximate a female dose, and it gets complicated. And unfortunately, even the gynecologists are not comfortable compounding. So we have kind of a medical system that doesn't support compounders because, compound pharmacies uh, are not doling out, uh, money-making prescription patented drugs. So they're kind of like the black sheep of the, prescription delivery apparatus in the United States. But we had compounders long before we had Walgreens. So the compounders were there. They've always been there. They're still there. It's just they're not as well known. But for hormones, they've seen a little bit of a resurgence because we need them. We need them to make estrogen testosterone creams. We need them to make some of our anti-aging hormone creams. We need them to make pellets. Sometimes we need them to make injectables for us. So we rely on compound vendors, and that's really why we use them because I can't just, yeah, I can't send a prescription to Walgreens for a testosterone estrogen cream or, but we do use, Rite Aid, Walgreens, et cetera, for other natural hormones like estrogen patches, for example. Most of our women are maintained on progesterone, which is commercially available as oral micronized progesterone, which is bioidentical. So it gets complicated, but depending on the type of hormone that you're talking about or how it's being delivered, you might need to rely on compounding. And unfortunately, again, traditional doctors and even gynecologists just don't seem to understand how to prescribe or connect with a compounding pharmacy. They're like literally, they don't know how to do it. So I think that's also a disservice to patients in this space. Not only do we have misinformation and over reliance on old crappy studies and fear mongering, but on top of that, we don't even know how to prescribe hormones in the US. In Europe, they've been using creams forever and stuff, but yeah, here nobody seems to know how to do it. And there's not really training in this stuff in medical school. I think that's, people assume their doctors know about this stuff because they learned it in medical school. They pretty much learn about birth control, and I don't even think testosterone therapy for men gets 5 minutes in medical school. I mean, honestly.
Yeah. Okay, before we get to the next question, I am curious about that. Obviously, people should just come see you at BioLounge, but if they don't have that opportunity, is there like a fellowship you should be looking for, any kind of training, or is it more experience? What should people be looking for a hormone litter?
Gosh, it's tough because there's so many organizations now that I think are trying to fill this gap uh, to educate providers. I got trained by the American Academy of Anti-Aging Medicine. I think they still do a pretty decent job in regards to hormone training for providers. You can go to A4M, A the number 4M.com, and click on their directory, type in your zip code. People who are fellowship trained through them have a higher level of training, so you'll see a lot more letters after their names like ABAARM, FAARM, and the like, versus somebody who just went to, 1 day conference and is now on their website in the directory. So see if they did, the A4M fellowship, they'd be a lot more adept in testing and things. Um, it's tough, and then there's a lot of people sort of promoting themselves as, being experts and stuff. And, there's still some kind of buyer beware. So it can be a hard thing to navigate, you know. Um, if knowing what I know, if I was in another country or something and I was seeking this kind of care, if I was a woman, I would be looking for somebody who had uh, experience in the space, who was adept in, all the different treatments that are available, who wasn't just, talking about one treatment or one therapy, whose background was grounded in science and medicine, who is visibly up to date in regards to guideline medicine as well as recent studies on these topics. A great book for women, by the way. You can stump the chump with your gynecologist if you read this book because you'll be armed with a lot of great information that they may not have read. It's called Estrogen Matters by Bluming. This is our number one recommendation for women who have questions about hormones, particularly postmenopausal women. And I feel like it's the handbook for women who are in menopause or approaching menopause, so they fully understand the controversy from 20 years ago and are well equipped to uh, really navigate conversations around HRT also with their friends. And I think we've done a good job scaring women. When we thought hormones caused cancer, there was almost $1 billion in lawsuits filed the next day. Doctors ran for the hills, and 50% of all females stopped taking HRT abruptly when the Women's Health Initiative study came out. So we're still dealing with that kind of fight. It was pretty tremendous fallout. It's like a big anvil came out of the sky and just crushed our hopes and dreams with hormones. So we're still dealing with that. But our guidelines have finally evolved. Like there was no change in the guidelines in almost 20 years, and now they've changed. So things are moving forward. We have social media, we have influencers, we have gynecologists getting on the pulpit, screaming about this stuff in a positive way. And I think the collective is becoming aware of this. These conversations I'm having with women are a lot different than 10 years ago. The conversations I'm having with gynecologists are different. So things are evolving, but we're still trying to screw our heads together from 25 years of giving women bad advice, and no one wants to feel like they've been on the wrong side of the fence for 25 years. So I think there's still a bit of a defensive posture. Or doctors will say, "Oh yeah, yeah, I've known that." Meanwhile, for 20 years, they were telling women garbage and telling women they were going to die if they took hormones. So yeah, but fortunately, this again, things are changing. Women's health is improving, and women have better access to better information that's less gate kept than it used to be.
Yeah. Related to that, Jeff, I'm thinking of my family who lives in the Midwest. Do you have a hot take on like some of these startups like MIDI that are doing kind of online hormones? Would you ever recommend that for someone?
I'd need to know more about their approach, but I think whenever there's an issue with access, I'd be a fan of anything that improves access
Yeah.
to good healthcare, right? So it's just are they sort of vampiring the broken system, or are they truly, on a good mission to deliver good healthcare to women?
Yeah. Okay, so we've got a question from Chris on behalf of his girlfriend, a woman on spironolactone for acne. She can't use testosterone for low libido, right? Because it will counteract the spiro and cause acne. How would you
Yeah,
react?
it may seem true on the surface, or even if you dig under the surface a little bit, but we have a lot of women on spironolactone and testosterone, and they do great. And it's because testosterone doesn't, it doesn't fully block testosterone, right? It's a mild antagonist. It's mostly affecting androgen receptors in the skin. I'll give you some examples. We have pelleted women who are on testosterone. The spironolactone doesn't really change their blood levels at all. But if they feel great otherwise, but have a little more acne than they want, uh, we offer them some spironolactone and they do just fine. So I think, again, on the surface, it sounds like a contradictory idea, but in clinical practice, it's absolutely fine to use both. Low doses of Spiro don't obliterate your testosterone. It's a little more contraindicated in men, but I'm starting to question that a little bit lately too, because it's not a full stop kind of thing where, a little bit of spironolactone, has any kind of dramatic effect on your testosterone levels. Certainly, if you're already on treatment, it's pretty negligible, but it does seem to help or curtail the energetic induced like oily skin or a little bit of facial hair growth that some women can get otherwise well managed on testosterone.
Jeff, will you talk a little bit more about testosterone for low sexual desire for women? Because I feel like that's an area that we still aren't talking about enough. So, how have you
We
used that?
don't we don't care too much about female libido, but testosterone. A lot of the studies on testosterone, the studies got going because female sexual dysfunction, has been looked at and probably accounts for more than 50% of studies in women on testosterone was to try to improve sexual desire or libido. And so, that's historically been studied. It does have a positive effect in that respect. Testosterone for women, just like men, affects your drive, energy, motivation, libido, workout recovery, ability to build muscle mass, burn fat. It affects your self-confidence, your mood. It affects depression in a positive way. It lowers inflammation slightly. So testosterone governs all those things in men and women. It's very much a female hormone, but it's been, genderified. And estrogen, by the way, is very much a male hormone too, male anabolic hormone, actually. It's just we demonized estrogen, and we've done a good job demonizing estrogen and testosterone. So when testosterone levels, change from baseline for women, they can start to express those symptoms, and then they can be potentially treated effectively with physiological doses of testosterone. And there's been studies on that going back to the late 40s. But a lot of these studies are smaller, they're not particularly well funded, but there's 70 years of aggregated data on these topics. Testosterone is used more in other countries. Australia has an FDA approved testosterone product. Europe is about to. They're trying to get a patch approved for women. We're going to be a few years behind that. It might be 10 years before we have an FDA approved testosterone product for women, but it's coming because there's a million studies showing it's safe. It doesn't affect breast cancer. It doesn't affect blood clots. It doesn't affect stroke. It doesn't affect heart attack. It doesn't do anything bad. If you use too much of it, you can get acne or oily skin. We're giving mega doses to people transitioning genders, and they seem to be doing fine too. So I think a lot of doctors will say, "Oh my God, you gave testosterone to my patient and their blood level is 100." And I'll say, "But you're super happy that your trans patient's level is 800 and you're not worried about them." So I think, and again, we have data to back up the safety. So there's a lot of knee-jerk reactionism to HRT. These are drugs potentially that can be abused. They're controlled substances, in particular testosterone. And there's a lot of historic nonsense, misinformation, and fear mongering and erroneous assumptions. So a lot of this work is really trying to navigate that minefield of negative press, if you will, on some of this stuff. And it's hard to navigate. This is not a topic you can Google and understand quickly. You know,
Yeah.
you can't even use AI. You prompt AI different ways, but you can still get the conclusion you're looking for. So you really have to step back and look at this topic with a really wide angle. And then you reach a pretty clear conclusion. It's not very ambiguous. So in regards to testosterone, there's not very many contraindications. Women should not be on testosterone if they're pregnant. That's pretty clear. If they have PCOS, they're already probably making too much. That might not make sense. Um, so there's some situations where giving testosterone is contraindicated, but there's very few, and it's a very safe hormone. So we're happy to support women's libido with testosterone, but also seek to understand why it's low. Again, that's what good functional medicine does. So is it low because they're overstressed? Are they in alignment with their life's purpose? Are they sleeping 2 hours a night? Do they hate their husband? What's going on?
Yep. Yep.
No?
Yeah. Okay. That's very helpful. We have a question on treatment. Is treatment covered, just HRT generally? This is from a man under insurance or typically out of pocket?
Yeah, it can be. I mean, when it's very in the box diagnoses and your PCP is happy to give you testosterone, absolutely. So, for example, here's some caveats though. Most insurance companies require a total testosterone below 300 or 250 for them to pay for your testosterone. So that's why when it's 350 and you say, "But doc, I have no erection and no libido," they say, "Sorry, it's normal," because they know that they're not going to get the insurance coverage. So they don't want to waste their time. Insurance companies will deny the claim. But if your testosterone level is, 290 and your doctor's okay with prescribing it, they can send a prescription for androgel or something like that, and it should be covered. So, I think the reason why there's so many men's health startup clinics around is because, first of all, doctors don't really want to deal with this. They're scared to give men testosterone. They're certainly not giving men testosterone if their level is 350 or 400. And then they have to navigate this insurance coverage minefield. So, uh, a lot of cash clinics spread up and say, "Hey, we're your solution because your PCP is never going to do this." Your PCP could do this in certain circumstances, perfectly, perfectly fine. It's just you have to thread the needle a little bit if you want to, you know, squeeze grape juice out of a lemon.
Yeah. Okay. Question on what would be considered low testosterone in a woman. Normal range on common labs says 9 to 55 nanograms per deciliter.
Yeah, 9 to 55 is actually a generous range. I think Quest is 10 to 40 or LabCorp is 10 to 40. So don't chase the numbers. I think a good question to ask is, what's my baseline? If we don't know that, let's look at the number a little bit more. Uh, Here's a question that should be asked. What's a healthy level of testosterone in 40 to 60-year-old women who have no health issues? Wouldn't that be good to know? What does a healthy woman with no real medical diagnoses on average show up to with in terms of blood level of testosterone? So somebody did ask that question, thank God. And they looked at, I don't know, 1,000 women or something in Iran who were healthy, 40 to 60. They said, geez, I wonder what their testosterone levels are. They were like 20 to 80. So occasionally I have a woman come back with a testosterone of 60, and their doctor will be like almost yelling at them that their testosterone is super high and oh my God, and blah, blah, blah. You're like, really healthy Iranian 40 to 60-year-old women's range are 20 to 40. Does that mean I'm a mutant if I'm 60 and I'm a man or something crazy? People get all excited about these ranges, and it's really odd. And I've seen primary care doctors, comments to patients just totally crazy. So here's the deal. It's probably 20 to 80 ish. So, we could consider 40 kind of an average. So, if you want to be at an average level, I think 40 is probably a number that makes sense. Free testosterone was something in the same study. It was something like I think it was like 2 to 8 or something, so different by a factor of 10 roughly. So I think it's good to know that study like this exists. Again, there's a lot of reasons we shouldn't chase numbers, not the least of which is different labs have completely different reference ranges. How are you going to interpret that? And then, there's a real divergence in your level based on your age, your level of health, and other things. So we really haven't like nailed down what's a perfect level. I think what we're looking for is expression of symptoms, changes from baseline, and does the shoe fit in terms of age, symptoms, et cetera, et cetera. So this diagnosis that you might be low in testosterone should not be based on a urine test or a saliva test or a single blood test or just a quick glance at your symptoms. You really have to artfully kind of put these things together before you draw any conclusion. But often, I'd be trialing a woman on testosterone if there's clear symptoms, especially around menopause. I mean, we know testosterone drops between 40 and 50, but even more so after age 50. And increasingly women, are trying to stay healthier longer. So they're hoping to maintain function of their pelvic floor, maintain sexual function, maintain normal libido through the lifespan, maintain and build musculature. And testosterone really supports women metabolically in the ways that they're already trying to do by eating more healthfully, doing weight training and other forms of exercise. Testosterone really fits with a lot of the other things that are becoming popular, in regards to lifestyle changes for women's health. So it really fits in with that picture of better metabolic fitness and sexual function.
Super helpful. Okay, we've got a few minutes left, so if there are burning questions, put them in. But Jeff, I'm curious if we didn't ask you something that you wanted us to, or if there's any wisdom that you really wanted to impart on us.
I saw another
Oh,
question in
go
there.
go ahead. Do that one first. Does testosterone tank around the same time estrogen drops, or are there not clear connections?
It's not as big as a drop off because you make testosterone in a few different places. So whereas estrogen is primarily made in the ovaries, there's more of an abrupt change. You still make a lot of testosterone in the adrenal glands. What I will say though is the change in testosterone around menopause has a lot to do with your resilience going into menopause. Imagine menopause as like a big challenging event in your life, like a triathlon or a huge test you've been studying for. And it's a pretty stressful event on the body. You have this huge abrupt change in your endocrine function. It's like a second puberty, you know? It's basically like reverse puberty. And so that's a shock to the system. You're getting like tasered with a life-changing endocrine event. So how resilient you are going into menopause predicts a lot of these swings in hormones, cortisol, testosterone, estrogen, etc. So if you're going into menopause and you feel great and everything is topped off in your body, your nutrients, vitamins, sleep, exercise, stress management, life purpose, it's all going awesome, you're probably going to coast through menopause. And a lot of the shifting of hormone production to the adrenals will happen very smoothly. We see that in Japan. In Japan, I think we talked about this before, but there's basically was in Okinawa, they didn't really talk about menopause. They didn't have a word for menopause. Researchers in the 1960s went to Okinawa to try to figure out why the hell these women were coasting through menopause with no symptoms. And they were just very resilient going into menopause. They had everything going for them, like I just mentioned. So this big shift was a small shift, and it was a very small shift. So it was going over a speed bump instead of jumping off a cliff, you know. So in this country, it's jumping off a cliff. That's why we have musicals devoted to menopause. It's like everybody's holding hands. It's Thelma and Louise. The car's going off the cliff.
Yep.
So
Exactly.
if we're not going off a cliff, this is easier. So what I tell my women who are 40s, I say, this event is coming, so prepare for it. Prepare for it physiologically. This is a time of life you should stop drinking, start sleeping more, go see your acupuncturist, exercise more, normalize your weight, do weight training, make sure all your vitamins and minerals are topped off. Make sure you do what you like to do in terms of work. Make sure you live with the people you like, you know, all those
Yeah.
things easier said than done, but it's a good decade in life to really dial in all those things. But it's also a very stressful time in life. So it's a time in life people have teenage kids, they get divorced, you know, whatever. They get sued, like their businesses are going through crazy stuff. So the 40s is a real nutty time in life. Unfortunately, it kind of coincides with menopause. So our modern life, again, here it's problematic for women, you know, times have changed and women are often, working and really stressed out and having kids. And it's like women are burning the candle at, both ends much more than they used to. So could this be another reason why women are suffering so much in menopause? Maybe our culture is just, you know, screwing with, I don't know. I don't know. I don't, it's like men too, you see hormone changes for a lot of reasons that you could chalk up to stress too, you know. But anyway,
Yeah.
the 40s are a rough road. So the smoother you can make that road, the smoother menopause will be. But the adrenals take up a lot of the slack after menopause. So your adrenals make testosterone. So your requirement for testosterone does not change abruptly, usually, but it can change. It goes at a different trajectory, let's say between, 45 and 55. So there might be like a real slow change, but then yeah, in that decade of 45 to 55, you might see that line kind of shift a little bit more. And those symptoms are very common, and I think most people don't know really how to work that up, or they do some fancy unnecessary test like, a urine or saliva test to try to like, read the tea leaves. It's not that hard to figure out. I mean, these symptoms are not very ambiguous. It's just we're all about like, estrogen and hot flashes. And when you learn more about testosterone, you realize it's actually a pretty clear, easy thing to understand as well. But yeah, it can be a little more slow and steady, and it requires a little bit more of a leap of faith, I think. I think a lot of doctors, frankly, are very scared to give women testosterone.
Yeah. Super helpful. Okay. Can you make enough testosterone with one testicle? I don't know the answer to
I
this.
think the answer is basically yes. And the same is true of one ovary, kind of yes, unless proven otherwise. So some men have undescended testes. We have several patients like that. So sometimes they're fine, sometimes they're not. When they're not, it's hard to know if that's just because of that or something else.
Yeah.
But it's not a absolutely, you're going to have a problem kind of scenario.
Okay. All right. I think we made it. Time flies. I think we need to make like a Jeff GPT so we can just ask Jeff questions all the time. I'll work on that maybe. Thank you all for coming. Thank you for your thoughtful questions. We're hopefully going to be doing more of these AMAs. So if anyone has ideas, feel free to send that to me. My email is Tara, Tara, at bioloungepdx.com. I would love to hear what would be interesting. Yeah, so fun to talk to you all. And Jeff, thank you so much. That was amazing.
Yeah, thanks, guys. We appreciate your attendance today. Share this information with friends. We're here to help, obviously, if it's helpful. But yeah,
Yep.
if you have questions you didn't get to ask, you could potentially email Tara and I can
Yep.
get to it later. And I think this was recorded, so there might be an ability to watch this again somehow.
Yep. We'll send it out.
All right.
All
Thanks, everybody.
right. Have a great weekend, everyone. Bye.